My name is Michael Oberst, and I'll be presenting this work, Characterization of Overlap in Observational Studies, which is joint with collaborators from Chalmers University, IBM, and Harvard Medical School. I'll be starting with a quick 5-minute overview of our work before diving into some of the details. We're motivated by causal inference in observational studies. Now, in economics, medicine, and a variety of other fields, we often ask questions such as, what is the effect of thiazide, which is a drug, on, say, a particular set of outcomes in a certain patient population. More recently in the news, you might have seen studies of hydroxychloroquine and its effect on adverse events in COVID-19 patients. And there are many more questions like these, but what ties them together is that they are causal questions. And we often find ourselves trying to use observational data sets to try and answer them. You can think of this as data from, say, the medical record, as opposed to from a dedicated randomized trial. But what do these studies look like, and how might the answers to those questions get used in practice? Well, this is an example of a comparative effectiveness study published recently in The Lancet, a top medical journal, which looked at the effectiveness of different hypertension drugs. And the punchline, so to speak, was that thiazide, one class of drugs, showed better primary effectiveness than ACE inhibitors. Now, as a clinician, as a doctor, how would you use that evidence in practice? Well, on the one hand, you have this study which says that treatment A is better than treatment B, but on the other hand, you have a real patient who's coming to the clinic. You know some things about her, let's call her Jane Doe, and you're asking yourself, do the conclusions of this study apply to this particular patient? And one way of answering that question is to start by asking, are individuals like Jane Doe included in this data set to begin with, the data set that informed this conclusion? So let's imagine on the right that these points represent the individuals who were in this observational study. We'd hope to see something like this, where Jane, here in the bottom left, seems to be well represented among this study's cohort. More broadly, we might consider this blue oval to represent the types of patients who are well represented in this data set. But we should also ask if individuals like Jane received both of the treatments, because after all, the conclusion is a comparison between treatments. Now, coloring these dots by the treatment they received, we notice that, again, remembering that this is from the medical records of a hospital, say, and not a randomized trial, it seems like there was an implicit policy in place where individuals below a certain age never received treatment A to begin with. Now, intuitively, that means that our conclusion that treatment A is better than treatment B probably can't be applied directly to patients like Jane, because patients like Jane in this data set never received treatment A to begin with. This yellow region, on the other hand, which we'll refer to as the overlap region, represents the types of patients who are well represented in the data and who had some chance of receiving both treatments. So that's the type of set of patients for whom we can actually apply these types of conclusions. And the goal of our work, and one of our major contributions, is to provide an algorithm, given sort of a study like this, to provide an interpretable characterization of exactly this overlap region, simple enough to be published alongside an observational study. Our approach we refer to as OverRule, and it consists of solving a certain type of classification problem using Boolean rule sets, and I'll get into more of those details later on, but the point of that is that it produces output like the following on the right for a famous job training data set. First, in blue, we have rules which characterize the support of the data, the types of people in the data set. So, for instance, individuals who are single with an income above a certain amount are not well represented in this data. And these yellow rules further refine the support down to the region where we can draw causal conclusions. So as one example, and there are more rules than the ones shown here, individuals who are below 27 and have no college degree are among those who are well represented in both the treatment and control groups. I should say that everything that I've talked about so far, the problem of overlap, which I'll detail more later, as well as our algorithm, applies equally well with minor modifications to this context of policy evaluation, where instead of comparing treatments, perhaps we're comparing a new policy suggested by an algorithm to existing practice. But now I'll get into some more of the details, starting with the importance of overlap. And to understand what I mean by overlap at more of a technical level, I have to tell you a bit more about how causal effects are estimated in the first place. So a very brief overview, where I'll leave out some details. Imagine you have some subjects for whom you observe X, their features, T, their treatments, and Y, their outcomes, and you're interested in their potential outcomes under all possible treatments, in this case, treatment and control. Well, under some assumptions, which I won't go into any more detail on for now, or in this talk, we have it that we can actually estimate these potential outcomes using our favorite machine learning sort of out-of-the-box conditional mean models. So anything that gives us an expectation of Y given T and X. And I should note that these assumptions are generally required to do any kind of causal effect estimation. But in this setting, here's the problem we run into if we don't have overlap. We might have a control group over here on the left in blue. We might feel very comfortable fitting this blue line to their outcomes, as a function of this abstract variable X. But what if our treated group is over here on the right? What if their values of X do not overlap with the values of X for the control group? Well, in that case, we're going to have to extrapolate. And outside of making strong parametric assumptions, it's hard to know which of these extrapolations is best. And in fact, we can't really verify, once we've picked an extrapolation, how well we've done, because we simply don't observe these outcomes. So as a result, the overlap condition is a crucial part of doing causal inference in observational studies. It states that for all values of X, that's features in our case, all treatments have some non-zero probability of occurring. Now, this is the sort of thing that you can check in practice, unlike some of those other assumptions, and it often doesn't hold everywhere, whether for reasons like we described conceptually, like there was a policy in place never to give a certain drug to a certain type of patient, or for reasons we'll see in a real data example later on in the talk. So given the importance of restricting our analysis to a region of overlap and characterizing that, I'll formalize the problem of describing that region well. The output of our algorithm is going to be a set, or a region, in the space of X. And we'd like it to satisfy a few things. We'd like for it to distinguish the support of our cohort. We don't want it to go beyond that support. We would like it to also be restricted to the region, say, within the support, where the overlap condition holds. And finally, we'd like to be able to describe it with a couple of simple rules. Based on that intuition, I'll give some more formal definitions. The minimum volume support set is how we'll characterize support. That is, we want a set C, which minimizes the volume, which in the intuitive sense, subject to the constraint that it captures at least an alpha fraction of the distribution of X, alpha typically being close to 1. We define the epsilon bounded propensity set as the set of all X in the domain, such that for those values of X, each treatment has some non-negligible probability of being assigned. And the overlap region combines these two, and what we'll be intersecting them. And what we'll be doing, our goal will be to characterize 1 and 2 using simple rules and intersect those rules to learn 3. Now, I've been talking a lot about simple rules, so I'll define what I mean. In our case, that's Boolean rule sets. One example of a Boolean rule set is a Boolean rule set in disjunctive or DNF, disjunctive normal form, or DNF for short. For example, the one given here, you notice that the clauses are written with ands. So for instance, age under 27 and no degree, whereas the separate clauses are brought together using or operators. Now geometrically, this gives us a union of possibly open hypercubes. But for our purposes, if these rules are simple, and if there aren't too many of them, it gives us an interpretable characterization of a region. So now I'll talk about our algorithm in a bit more detail. Remembering our first goal was to characterize that minimum volume support set, and with this on the right as our illustrative data, we first note that calculating this volume is challenging for Boolean rules, so we approximate it using background samples. We draw background samples uniformly from the domain, and then we realize that we can reduce this to a straightforward optimization problem. We minimize the number of, or rather the fraction of background samples that are included in our set, where again, our sets are going to be Boolean rule sets, plus some regularization to make sure that these rules are simple, subject to the constraint that we capture at least a certain fraction alpha of our original data points. Now this is already a Neiman-Pearson classification problem. We're minimizing a false positive rate of sorts, subject to a constraint on a true positive rate. Now, formulating this with Boolean rules naturally leads to an integer linear program, and we use some recent techniques in the references there to solve that. And that might give us something like these blue rectangles on the right. We then keep the points that were selected by those blue rectangles, and we go on to construct our bounded propensity set. Now, in this case, we can look at the treatments all of these points were assigned, and we can take as a black box any propensity score model that gives us some probability of being assigned each treatment. Using that, we can simply assign pseudo-labels to points based on whether or not they satisfy this condition. Then, as before, we learn Boolean rules using similar techniques to the ones I just described, and we combine this rule set with the previous rule set, given here in blue, to get the overlap region in yellow. Now, there's other work on this topic, in a sense. Propensity scores, matching, classical methods typically throw out data points in order to potentially try and ensure overlap, but they don't give an explicit interpretable characterization of the resulting region, like what we're after. Maxbox, which is a comparable or a comparator to our algorithm, it's one of the baselines we use in the paper, also learns interpretable descriptions of a region, but it's restricted to one box and it doesn't characterize the marginal support. And I'll talk a little bit about why that's important. In this illustrative example, we get to that point. We're using the iris data set, but really just for conceptual illustration. We take two of the species in iris, and we treat them as our treatment and control groups. So that's the blue dots and the red triangles. And that's our entire observational data set in this thought experiment. We run our algorithm, we run Maxbox, and the regions they output are given here in yellow. And I would just point you to the fact that the region output by OverRule adheres very closely to the red and the blue points, and does not include many of the black points, which in this conceptual illustration might be new patients who come into the clinic who don't look like the individuals who are in our original data set due to differences in their covariates. Whereas Maxbox is a little bit looser and goes a bit outside, arguably, the support of the data. Now I'll talk a little bit about an application and a user study before concluding. The application is opioid prescription. We put ourselves in the shoes of a researcher interested in the effect of opioid dosages prescribed after surgery and their effect on downstream substance abuse. We use data on a large number of post-surgical patients, particularly their medical insurance claims, and we review the results with a panel of surgeons to understand if the rules that come out of our algorithm for this application are clinically sensible and interpretable. I'll quickly skim through some rules, but I would really just highlight that the rules we find are relatively straightforward and interpretable, in addition to being clinically relevant. For instance, the second rule essentially says that long doses of opioids are not given to mothers who just came out of a C-section. I'll just wrap up now with some conclusions. So machine learning has a lot of promise and a lot to offer in causal inference, but we should be clear about the bounds of our data when we communicate results. We've presented a method based on Boolean rules that provides a simple interpretable characterization of those bounds, as well as being simple enough to publish in a study. And with that, thank you for listening. And you can see the paper for more details, particularly those details on generalization to policy evaluation I mentioned, as well as code to replicate some of our results. Thank you for watching and enjoy the rest of the conference.